first question then is, how do we educate the public better on the link between hearing loss and dementia? So who would like to start with that one? Brian.
I should also confess a past life to being responsible for communications as well, so might be informed a little bit by that. I think first we have to define who the public is here, and I think the starting point actually has to be other people within the health system that are responsible for communicating with the public, because the idea that the hearing sector can easily do this on its own, I think is a step too far. So we actually have to look across the system at other health educators, and especially in the UK context, therefore that's as much about public health as it is about NHS England, and I think that's one of the major problems. I think there's two communication challenges there, and the first is that neither those health professionals nor the public understand what the impact of hearing loss is on their lives, and therefore doubly trying to make them also understand the impact of hearing loss and the association with dementia gives us a double challenge. I think the first place we have to start therefore is with, what does your hearing do for you? And as Helene sort of explained, there's a whole number of things that does. Then within that, I think the dementia one could then be one of the strongest ones in terms of capturing people's attention about why they might take more care of their hearing loss, simply because if you look at most families, because of the incidence now of dementia, most families at some stage are going to be touched by someone in their lives that actually has dementia, and therefore I think there's also a major opportunity in a link to do something about that. But we have to, I think, put it in a broader context about what does your hearing do for you, and getting people to understand that. And then one of the big answers to that is actually it gives you better cognitive health. And I think lastly in both of those we need to be talking more about not what you lose but what you have, because I think when you start to frame everything around hearing loss, you're straight back into what some commentators were talking about this morning in terms of this is a not for me issue, it's about becoming old, I don't want to accept I'm becoming old. And therefore the more we talk about something positive, which is hearing health and cognitive health, and putting those two together, I think that's how we need to be framing this.
Very good. Esri, do you have a thought on this one?
I agree with Brian. In our research, after having our research, we try to present it in our research user group. So it's around 10% with the hearing loss and then dementia or with some cognitive decline, something like that, and the carer. And then they say to us that our GP should know about this because this is not us who take the decisions, not only us. So there is some people in the health system that they should know about this. And then they also say that the people who responsible to care for the older adults, they also feels that they need to know about this result.
Okay. Any other thoughts?
Yeah, I totally agree. It isn't for the hearing industry necessarily to try and get people to screen or take screening, because having been in the position where you are offering screening, and I'm sitting there talking to people as they come in at the door in an optician's, do you just want to have your hearing screened while you're here? Is extremely difficult. There's nothing wrong with me. So there has to be a policy decision. This is something that needs to be done, should be done, because many people won't take it, and it's also very difficult sometimes to train people to approach the public, and the right way to approach them is to get them to take the offer of even a free check, because if you handle it in the wrong way, it's not taken up.
So Tony, how do we, as the question suggests, how do we better educate people? I mean, would a national advertising campaign, for example, do the job?
It would, but this has been done, if you like, in terms of adverts. So some of the national high street brands will actually use advertising that you should have your hearing checked. It works to a point. People will take notice, but that's normally because I've got a problem, I need to do something about it, rather than, oh, I should do that because I get my eyes checked. or because I go and have my teeth checked. And you'll see that tweeted a lot. You teeth check, tick. Eye check, tick. Hearing check, cross. And you'll see that in a lot of advertising used. People don't take that responsibility. So it is very difficult to get people to understand that they should be doing something earlier before it becomes a problem, than leave it to when it does become a problem.
So it's kind of hearing well throughout life rather than waiting.
It is, and almost we should have a baseline, say when they're a teenager or early 20s, that everyone has this test done, and then we monitor them at periods through their life if there's any problems. But how do you put that type of thing in place? The cost...
Peter, your thoughts on that?
Well, I'm not sure I can properly answer how best to educate. I would just flag up there's lots of different audiences here, and I think this has been touched on. There is the public directly, and you could use this argument as something to inspire people directly to go and get their hearing checked out. There's also GPs. If the GPs are aware, they may be more incentivised to properly refer on. And then there's politicians. There's people in the Department of Health, NHS England, and in clinical commissioning groups themselves. So I'm not necessarily proposing a solution here, but just to think about there are lots of different audiences, and they may need slightly different strategies to influence them.
I think this morning Tony mentioned about stigma, the word stigma. I mean, obviously that does play quite an important role in some people's decision making. They will put it off because they don't want to wear hearing aids. I mean, how big a problem is this? I mean, is this something that we can overcome over time? What do you think, Helen?
Regarding stigma?
Yes.
Yes, yeah. It's interesting because we are right now analyzing data in our cohort regarding stigma, because I think that it may be an important barrier for communication, for education. I don't want to wear this aids because if I show this, then I show that I am old and I'm becoming disabled and so on. We just ask a very simple question to participants in the backward study. Well, two questions. How old are you? Very simple question. And how old do you feel? Mm-hmm. And we show that it's not published already. We show that people with hearing loss feel 10 years older than the others.
Interesting.
So it's really a stigma, an important stigma of aging, and probably a barrier regarding the way the others will see me. I just, in line with what has been said earlier, I think it's a bit funny because if we think about education, we try to inform general population about two conditions which are dramatically considered differently from in general population. I mean, hearing loss, which is considered as perfectly normal, because it's very frequent, then we are inclined to think it's normal. Hearing less when I get older, it's normal. And on the other hand, dementia, which is probably one of the most feared diseases after cancer. There are some studies showing that the second disease most feared by general population is Alzheimer's disease and dementia. So the challenge is to help people make the link between a normal condition, hearing loss in older adults, and a condition that dementia, which is feared by all people who want to get older, but without this terrible disease which generates disability and so on. So it's kind of challenge to make this relationship between both something normal and something so terrible as dementia.
And Sergio, your thoughts on this?
Yeah, I mean, I would say in the UK it's the most feared condition, dementia, in older adults. Yes, in older adults it is. So definitely there is, that way that people put to avoiding that condition, and I think probably framing it in the context of healthy aging is the right way, as a positive message that really should start in middle age, and in the same way that when you go to the GP and you're 40, they check your blood pressure, and if you've got these risk factors, they're going to tell you you should take statins or you should do more exercise, more likely. Hearing loss should be included in that conversation as one of the factors that that should ameliorate or reduce the risk of these conditions in later life.
Okay.
I think from GPs we still hear quite a lot of stories that people say they've been to their GP and the GP told them not to worry because yes, you're getting old, there's nothing you can do about it, it'll just get worse. There hasn't been support. I know an Action on Hearing Loss did a circulation to GPs, didn't they, a couple of years ago. I don't know what the impact was to encourage them to look at hearing more closely, but we still get these reports that people have been to their GP and were told not to worry about it.
Yes. I mean, this is an issue, we know it's an issue, and we at BIHIMA are working with Action on Hearing Loss, as I mentioned earlier this morning, to try to address this situation, at least have some kind of impact.
Yeah.
So does anyone else have any other thoughts on this particular question? Educating the public better. I take your point, Brian, that it's also...
Yeah, just to go back to the point about where responsibility for this lays, and I certainly think in the UK, the failure of the public health system as opposed to the NHS board to actually really grapple with the evidence around the various comorbidities related to hearing loss, of which now the dementia's the most obviously powerful in this context. And I think the more we could actually get them to think about that as part of that programme for healthy ageing. So, public health are now massively into getting people to lead healthier lifestyles, and that may all help impact on the dementia part of the argument. But it seems to me they are still missing the massive opportunity that exists around the linkage between hearing loss and dementia. If we could really get public health to own this, and then you could start to see it come out into, being added to screening programmes that are mandatory. That it's a bit like nudge theory. You say you offer somebody something as part of their routine screening. You don't ask them if they don't want it. They have to opt out. And so as once you've got them in for the screen, it's just, now we're going to check your hearing. And now we're going to do this because it's just part of healthy ageing. Why is it part of healthy ageing? Well, it's going to reduce your risk of dementia. And then I think you start, okay, that's a reason why I might want to be far more interested now, rather than the inevitable normality of losing my hearing. And I think that's the other bit of the challenge. It's not normal in the sense of it's not addressable. And I think one of the biggest ironies we've got is we've probably got the best possible technology we've ever had, whether you're thinking of hearing aids, cochlear implants, other devices that can help you hear really well, that we've still got a massive problem in persuading the public to do something that would be of such benefit to them.
So it's in a way an holistic approach that's required, isn't it? I mean, it's not just one sector coming at this. I mean, for example, the manufacturers coming at this, we need to educate, the educators, almost. I mean, we talked earlier about the dispensers. So, Victoria, do you have a thought?
I come at this from a different angle, and everybody in the UK is screened for their hearing twice now already. When we're born, and when we start school, but then we don't continue with it. Yeah. So I think we need also a more long-term perspective, and we need to go right back to those hearing screeners with the newborns and get to mums and do it that way. So as a mum, I take my child to have back to that hearing check, teeth check. I take them for their dentist appointment every 6 months because that's what I was told to do as a mum, and that's what I know. I take them to the opticians.
Yes.
I work in audiology and I don't take them for the hearing test. They had the hearing screening at birth, and I had paperwork from there, and I was told by the screeners why they were doing it. They had their reception class check when they were 5. I think we could tap in there somehow. I know that's a much longer term.
I spent 20 years in optics, and the transformation that we saw over those 2 decades. I mean, at one time when I was at school many years ago, it was specky 4 eyes, and no one wanted to wear specs. Now they're fashion accessories. Now we don't expect the same to happen with hearing, but I think.
But why not? It happened with braces as well. I think we need to learn from other health sectors.
Yes, but I take your point about early intervention.
But and the screening's happening there already, so if we could somehow use that.
Yeah.
Sorry. I've
I think that's
before about that. I get a bit
that's a very valid contribution. Very valid.
Sorry.
The other trend that might also facilitate this normalization is that you go in the tube, everyone is wearing something in their ears. They're not hearing aids, but they're there's that channel and that normality that wasn't there even just 10 years ago. And whether this could be a way, if you use the technology in your ears, when as you get older, maybe the technology that you need will also include a part of augmentation and support of your hearing.
Yeah. So in fact, the question is about educate the public better on the link between hearing loss and dementia, but it need not be necessarily the link between hearing loss and dementia. Does it? I mean,
no. I mean that I think is part of my point. That in a way, if you can just get people to value their hearing more and hearing well, there's a whole number of health consequences that follow from that. One of which is dementia. I think dementia for a certain age group could be the strongest driver in terms of doing that, which is why I think we're also interested in it at one level, and it's kind of revolutionised to some extent the way we're thinking about this, because it does look like it's a thing that can actually bump hearing loss up the health agenda in a way that some of those other things haven't managed to do. But I don't think you can just go in and scare people on the grounds of, if you don't do something about your hearing, you're going to get dementia. I think you have to talk to people about what the hearing does. And the really good news is, if you have better cognitive health, you're going to be much less risk of getting dementia from everything we know. And here are these amazing hearing instruments that can help you do it. And then I also agree at that point, for those generations that have grown up with wearables and aren't at all embarrassed by sort of being on the tube with a great big pair of cans over their heads, by the time we get that generation through, I don't think there'll be the same issue about wearing behind the ear hearing aids and those kind of issues. And by then I imagine it'll be integrated into all sorts of other things anyway. But I think you start with, what does your hearing do for you? And we don't really understand. All the surveys show the public don't really understand what their hearing does for them.
Yes, so in other words, if there was a communication message, it's more about look at the positive things, the good things, rather than necessarily concentrating on the negatives that people want to shy away from. So, I think that's a pretty interesting.
But I would also totally go for this idea, if you had routine health screening and you carried that through, then it's a real nudge to make people, well, why is someone screening me for this? It must be important if someone's screening it for me for it. What's that about? What am I protecting? And I agree, if you're looking for long-term change, the kind of messaging, just the implicit messaging of the state thinks it's important enough to find out how well you're hearing and help you hear better, has an opportunity to do the really long-term shifts. I think advertising is, except in a very tactical sense, very, very difficult if you're looking to shift public perceptions, because you either need a vast volume of it to make any impact, and even then you have to be very, very clever about how you're doing it, not to actually push people away from the issue, just as likely to turn them off as you are to turn them on.
So would you say that public screening, health screening, hearing would be top of the agenda? Would it be priority number one in terms of an initiative to move things forward?
If you could do one thing very simply, that would be it, because it would, for me, lock into the public health agenda I was talking about. Because you couldn't do that without integrating it with some of the other public health programs and messaging, and it would start to integrate hearing loss into that. And as you were saying, because it's not part and integrated into any of that, Well, the messaging therefore is it's not important.
So would everyone agree with that screening would be probably priority number one?
Yes, regular screening.
I would agree. I would point out the difficulties in doing so, because over the years, multiple attempts have been made to the UK National Screening Council or Committee, not sure I'm getting the acronym quite right, to do it. So far, they have not been receptive. What they're looking for on one front is randomised controlled trial evidence that screening works. That screening will lead to increased uptake and the benefits that you think will happen from that will occur. As of yet, that randomised controlled trial hasn't happened. And I think the last time a push was made on this, that was what they kind of said was the sort of this next stage, sort of come back to us when you've got that. So I just want to throw that out there, the kind of the difficulties in doing so.
Yeah. Okay, unless anyone else has got anything else to contribute on that particular question, we'll move on to question 2. So if hearing loss is a modifiable risk of early onset dementia, what is the solution? It's a modifiable risk. What is the solution? Anyone have any thoughts on that? Who'd like to start?
Hearing aids.
Hearing aids. Okay. Is that an easy answer to the question? The first.
It's not an easy answer because it's not just the hearing aid; it's how it's fitted and how it's managed in the long term as well. Because a lot of people will take a hearing aid, and that's it. They won't use it correctly. You'll often see they're not quite fitted correctly because there's a lot of variables in a hearing test alone, let alone the fitting process. Hearing aids are designed to work on the average person. So there's a lot of personalisation, and often the delivery system doesn't allow the time to make that personalisation happen, to make it most effective for the person who's going to wear it. So there are a lot of issues around it, but yes, a hearing aid, when this is appropriate, is definitely the answer.
How would you deal with some of those issues you've raised there?
Personalisation is very difficult. It's quite subjective. It does become easier. I mean, the way we calculate how a hearing aid fits, it's quite accurate for the average person. But we all have very different lifestyles, and it's finding out more about what they want to wear the hearing aid for, how they're going to use it, what they expect out of it. Matching that hearing loss to their requirements, matching that hearing aid properly to their ear size, to their hearing loss, allowing for variations in test procedure. It's all very time consuming. It can be done and you can get very good results. In fact, we do get very good results because we see the figures that most people get on much better than expected with hearing aids. But it can be done better in many cases.
And why do you think it's not happening in almost all cases? Why is that?
It's a difficult one. I mean, manufacturers work very hard to make a hearing aid as quickly fittable as possible, if you like. So we want to get to the right answer as quick as possible. Now, you could take it, I'm going to fit a hearing aid and use the manufacturer's algorithm, and it's going to fit, and that's going to be right. And the person says, OK, I'm happy with that sound. But that algorithm is based on the individual. So what you need to do is accept that they're hearing better, but then see if you can make them hear even better. And that process can take months. Slowly going a little bit further each time, pushing the hearing more open, pushing the boundaries of their hearing, pushing the boundaries of their lifestyle. That doesn't necessarily happen because we see a hearing aid as a hearing aid, not as a facilitator for improved life.
So would it help if there was a more standardised approach in terms of dispensers and audiologists in terms of dealing with patients?
My problem is standardisation, is that if we fit everything to a standard way, it doesn't necessarily suit the individual.
Right.
So I think flexibility is very important. Again, it's a difficult one. We should have obviously procedures in place, and those procedures are there. does everyone follow those procedures? Does everyone follow those procedures in the same way? Does everyone look at what the subject, if you like, is saying? You've got a hearing loss, I'm going to make it better. That person has very particular needs, and we should be listening to them more rather than looking at what we're doing for them. And that's sometimes missed, I think.
Okay. Sergey, do you have any thoughts on this one?
Yeah, so, well, two thoughts, I suppose. One is, so we did a feasibility study, thinking about the pathways that lead from someone even having the awareness of okay, yes, maybe there's something with my hearing, and I heard something about dementia, I should do something about it, and actually getting the proper treatment. So we before the pilot, we did a small feasibility study where we basically looked at people in our clinic in Islington Memory Service. We had just diagnosed them with mild cognitive impairment, and we tested their hearing. Out of 17 people, there were 12 who had untreated hearing loss, which, not a bad percentage, small numbers. And then we wrote a letter to the GP saying, dear GP, we have identified a hearing loss. It's, take this test as a research test, only not ideal because we did it at the person's home. But, it does look like they might benefit from amplification. And out of the 12, only 3 people got to see an audiologist. Out of the 3, only 2 got hearing aids, of which one almost immediately told us that was after 3 months, that they were having already problems, they were likely to abandon them. So I think we need a lot of work. So is it the hearing aids the solution? Well, certainly a big part of the solution. But do we need to work on the pathways? And are the pathways adequate to the task? I don't think they are at the moment, at least not based. Our patients have mild memory difficulties, but so do a significant percentage of older adults. So, I think the moment that you're not a standard patient, then you're going to have a high likelihood of failing that pathway.
Interesting.
Yeah. The other one is kind of a bit the opposite. The other idea is that, going back to the fact that people are getting used to wearables, are there ways to perhaps not so personalized, but are there ways to integrate amplification into that? To create, it's completely out of my area of expertise, but more quick and easy partial solutions to those problems.
Yes, that already exists, and there are programs that will allow you to do that. I think another thing that's quite difficult is many people will have a problem with hearing. It might be a mild problem 99% of the time. They'll only take a hearing aid for that very difficult situation, which may be noise, where the hearing aid doesn't necessarily cope that well, because we all struggle in that noise. Even though that hearing aid may help them 99% of the time, they can manage, so they reject the hearing just on that 1%. So it is very difficult. So anything that gets people aware that yes, we can slightly improve, and you're right, there are programs that exist that can be downloaded for your phone to actually personalise the response. If people start becoming aware they can do these things, they are managing better, they will be more accepting later on when the problem gets worse.
I suppose quite a number of older people are not tech savvy.
Very much so.
They?
Yes, and
so using the internet, using apps is not necessarily going to be easy.
And dare I say, a lot of audiologists and hearing aid dispensers are not tech savvy either, which is a difficult thing to actually relay that then to the user.
Lots of variables here, aren't there? Lots of variables. Very difficult to pin them all down. Any other thoughts on that? Yes, sir.
Yes. As I said before, that we, in trying to disseminate our result, we talk to the people with the hearing loss and older adults, and then also with the carer. And then I think the family supports and the carer support. So the information that we gave not only to the patient but also the carer and the family, because they are actually the one who understand the difference before and after using hearing aids. They say that previously my mother did not respond when I talked to her, so I just let it like that. So I will not talk to her so oftenly. But now, because of she can listen very well or better, listen to me, and then I then love to talk to her again. So I think the one that recognize the difference and the one who will remind the older adults or the people with the hearing aids to always use it and then interact with them is actually the family and the carer. So we also should give information and support to them.
So any strategy really involves the carers, the support team around the family.
Yes.
Yeah. Very interesting. Any other points? Yes. Peter.
Yeah, so I'll expand on my hearing aid two-word answer earlier, because I think hearing aids are the solution. Cochlear implants, I should say, as well. But it is, as Tony alluded to and the other speakers, it's not just there's a whole structure around this. And there's a whole, if you look through the whole chain, there's things we've already discussed, like public awareness, there's screening, and then there's the system itself. And something that would be perhaps quite useful to promote is there's the commissioning framework in this country for adult hearing services, and that really is a guide to clinical commissioning groups, the people who commission NHS services in this country, how they should set a service up. And it does give leeway for audiologists to sort of individualise things, but it's more on a sort of service provision level. And I think that is such a good and useful guide that we have already, that promoting that a bit is part of the solution.
Thank you for that contribution. Okay, let's move on to the next question. What research is needed to demonstrate the value of hearing aids to this issue? What research is needed to demonstrate the value of hearing aids to this issue? Let's start with you, Erna.
I think that you gave the answer.
So that's the answer, is it?
I think we need interventional studies to provide the formal proof, but we also need to we don't have to ignore what has been done already, because it's a bit easy to say there is no formal proof from clinical trials, so let's do as if we didn't have any results showing the strong association. So I think that, of course, the next step is clinical trial with an intervention on randomized groups, controlling the selection bias, because that's what we cannot control in our epidemiologic studies. The fact that maybe the participants that we study are particular participants, and maybe we could not generalize to other people who are not inclined to participate to this kind of studies. So we need clinical trial, but we don't have to ignore what has been done. And I think that it's a bit easy to say, let's wait. Yes, but we can do already some things, because we don't have nothing to support this association.
Soki, would you agree with that?
Yeah, absolutely. So I think that we have now very high quality and very consistent epidemiological evidence that hearing loss is a risk factor for dementia, and that acting on hearing loss through amplification is likely to provide benefit. I think, so there will be more work coming out, but I will be very surprised if suddenly the story completely turns, because the level of consistency that you see in the epidemiological literature is really remarkable. It's not often the case that you see that. But I think we need to go so for the early adopters or the informed minority, I think anyone looking at not necessarily the scientific literature but the newspapers, they will be already in the know that they should be, if they want healthy aging, they should be treating their hearing. That's great, and let's have more of that. But if we want the population as a whole, the people who perhaps are less inclined to look after their health, who will only do it if their GP says, well, this is important, I think we need the trials, because we need to work through commissioners, we need to work through public health structures, and we need to provide absolutely, solid evidence of cost effectiveness, and that will come from a clinical trial. That said, we are at the beginning of a wave of trials. We were talking about it earlier in the break. So there's Franklin in the US doing a trial on primary prevention, so do hearing aids in healthy aging in people who don't have cognitive impairment. Do they reduce cognitive decline? We have secondary prevention in people who are starting to have memory problems. We are working on finding out if we can prevent or reduce the decline. And we have tertiary prevention in Manchester and in Europe, the SenseCog project looking at whether in dementia, if you treat hearing loss, you reduce the decline as well. So, but we have to see that this is like the beginning of really a full program of research that could answer these questions.
So from your perspective, Brian, I mean, is there research that needs to be undertaken that we haven't talked about, or an adjunct to existing research that you think is missing from?
I certainly think from the point of view of health policy and influencing people within the health system about commissioning or encouraging people to take action about hearing loss, the big gap in terms of certainly around hearing loss and dementia, and it may just be that I didn't find the studies, but studies combining hearing loss and dementia and the potential cost-benefit, cost savings. So I've managed to find just a couple. They're very good. They're very, very methodologically sophisticated. But essentially, if you're going to make the argument, assuming we know one way or another, we're going to find out the very specific causes through these next tranche of studies, and there isn't going to be some massive veering away from the narrative. It still wouldn't necessarily say what the total impact on people's lives was, plus cost benefit of doing something differently. So I think what we need to go alongside these studies is something either second order that just looks at the numbers and hypothesizes from what we know, or actually has a more fine-grained approach of actually trying to look and calculate the potential differences in particular different areas. But essentially we need to build up a kind of cost-benefit analysis that goes behind the causation analysis, because just saying that, well, we know if you've got dementia at that level and you wear a hearing aid, you address it by 3 years. At a very broad level, you can say, well, that might save the overall system X billion dollars or pounds. But then if you're the House Commissioner, you want to know, well, what exactly should I do within that? What's going to do the most by when? Is it giving everybody hearing aids at 60? Is it the screening test? Is it that plus this house programme? And building up what the exact intervention I'm going to support. That's why I think there's quite a gap. I think we've caught up on the simple hearing loss side, so cost benefit around hearing loss. I think in your Bridget Shields study, the latest, but there's a number around showing various elements of that. But the particular interface with dementia, I think more could be done around that.
So there's no magic bullet, and even if there were, would it be possible to persuade the policy makers, the people who sign the checks, to actually back this? I mean, do you always see there's going to be an issue, no matter how compelling the evidence is?
There's always going to be an issue, because for any health system, there's going to be less money in it for as long as we can see in the foreseeable future than there is demands. And hearing loss, and even hearing loss and dementia, is still going to be up against dread diseases, cancer, heart disease, mental health, and certainly if you look at the way the debate's gone in this country, and it's not about just trading one condition off against another, but you look at the NHS forward plan, and it's really driven by those very big issues and social care in general. And therefore, it's not simply going to be on the cost-benefit analysis. I think it's also going to be on where that fits then within those other health streams. And that's why I focused in my talk on the issues around health costs and social care costs, because that's what's going to kill most governments in the Western world over the next 15 to 20 years, around the issue of dementia, around the issue of mental health, hearing loss, elderly population. So for all of them, the big political game is going to be healthy ageing, and it's how much the state has to pay and how much you can get individuals to pay. And as we saw, a lot of the dementia piece at the moment, it's actually individuals and families paying anyway. And so essentially what you've got to do is find a way of inserting the hearing loss and dementia argument into that broader argument about social care and how we pay for social care. I think that's where you could do a brilliant piece of research, which is how much of the social care budget could you address and reduce, and then how much of the impact on families, which although the families may be paying directly, the state's then picking up all the health issues that those families get because they're carers. And so if you could put all that together in a political argument that says if you really want to address the costs of ageing and social care, you've got to address the costs of hearing loss and dementia, I think that's the point you might shift the health commissioners, because although it all makes very rational sense, it's all about jam tomorrow. And what nearly everybody in health systems and politicians want is jam today without having to invest for jam tomorrow.
Well, I think you enunciated that extremely well. I mean, what you're saying, in effect, is that it's got to be, I come back to that word I used earlier, an holistic approach. Everyone has got to work, all the different departments have got to work in harmony to persuade the policymakers, the people who spend the money, that actually we are saving money if we invest in this.
Yeah.
And it's not just investing in this, it's a part of...
Yeah. And the one thing that's starting to go away, I mean, the big argument against what I've been arguing for all along is, well, governments run in silos, and it's no use showing to the health service you're going to save in the social care budget, because that's local authorities and it's a different budget, so they don't care. And that's all been true to an extent. I think what is interesting about the NHS plan is it recognises that, and it recognises it can't keep going on like that. So all that's happening is the system is offloading costs between different bits of the system and not fixing the problem. And at least there's the start of a recognition and attempt to say that this has got to be more integrated. And this whole shift to primary care and away from acute care is all about recognising that you've got to start joining up the healthcare, GPs, local authorities in local communities. Now, we can all feel a little bit sceptical about how serious that is, how far it's going to go. Are the systems going to get in the way of really making that happen? But I think there's at least a recognition in the system that something's got to shift. If we can get in on the back of that and say, and yes, part of that is how you deal with these issues, we're at least in with a shout. I wouldn't say it's easy at all. We're still going to be really fighting for our corner against all those other issues that will appear far more obvious as candidates for investment.
So with a clean sheet of paper and with all your knowledge and your background, your history, and with what you're working on right now, what would you do differently to try to achieve that longer term objective of getting all these elements to work together to persuade government to move?
Do differently in terms of how I would lobby them, or if I was government, how I would do it differently.
If you were now charged as of today to be responsible for driving this initiative through, I mean, what are you going to do? What are you going to do differently?
I think it's about doing, I think, what the sector is trying to do, which is collect the best possible evidence from the brilliant researchers we've heard here today. I think you've got to try and align that with the economic argument. Maybe that's the piece that I think is still a bit missing, is how you align that with the economic argument about that. Then the third bit is somehow, as a sector, working ever more closely together. Because that's always been, if you look at what's happened in mental health, the sector decided they really had to come together. and work as a sector 15 years ago, you can see the results of that in the latest NHS plan, where mental health is absolutely front and centre of that plan now. It's taken them 15 to 20 years, I'd say, to get there, but they did it by working together as a sector from the bottom up, working with families, working with users, and building the whole thing up. And in a way, we've got to invest for the future and as a sector in working together like that. And I think in iCare, to some extent, that's what iCare did 10, 15 years ago. And I think you can see the impact there as well, in terms of money spent, profile of issue. I'm sure it could be better, but but that's not an easy answer. It's not going to happen tomorrow.
It was a difficult question, but thank you for your response. And Sergey, you were going to respond to that.
Yeah, I mean, I would agree with all the complexities that you outline, Brian. I would add that this wave of trials that we are, now at the beginning of, they do have a health economics component. They all do, and they will be able to answer questions like, for example, if someone has memory problems, if we put a screening procedure at the point of diagnosis of their memory difficulties and act accordingly, will that save money? And that will be a rigorous, we don't know what the answer will be, but that will, if it is in line with epidemiological evidence, that would provide rock solid evidence of pounds and pennies. So a bit more optimistic.
That'd be brilliant.
Very good. So, does anyone else want to add anything to what we've said already on that particular question?
So I'll just, first of all, reinforce everything Brian said. I agree with all of it. Just to give perhaps the same hopeful example that he gave of mental health, because that's where I was working prior to coming into the hearing loss sector. I think the most effective bit of lobbying in the last sort of 15 years in this country was in the mental health front on getting psychological therapies onto the NHS. And that was a brutally simple and effective thing. Had a bunch of evidence of from randomised control trials of the effectiveness of cognitive behavioural therapy for depression, that then showed the government, here's all the money you're spending on incapacity to benefit due to depression. Here's how much it costs to give a course of cognitive behavioural therapy. Look. And that led to sort of the largest in Europe, perhaps the world, expansion of cognitive behavioural therapy on the NHS.
So there is hope then?
Yeah. No, I totally agree. That's a brilliant example of what I was talking about, that can be done. Because everybody says, oh no, the cost-benefit analysis, government never listens to them because it's always jammed tomorrow. But actually, if you get it right, like they did, like they did in France over the free hearing age, you can make a big shift.
Yeah.
So I think that's the cause from optimism.
So I think the final question really is, what is the group's shared call to action to see these steps are taken? I mean, what do we need to do next?
Can I just ask, do we just confine this to dementia? Do we look at the whole process in terms of depression, everything else which has that cost? If you just limit it to one aspect, does that limit what you can do in the future?
Almost certainly, yes.
So should we expand this to include dementia as part of the project, if you like, and look at the whole effect?
I can see Sergey nodding yes, so I'm going to agree with him.
But absolutely right. I mean, and also depression and social isolation are probable steps in that pathway, isn't it? It's just that I suppose, it's not my expertise to craft public health campaigns or things like that, but I think you kind of need an anchor, isn't it? And dementia provides that final anchor and says, and also depression and so on. But obviously, when you're going to look at the economic analysis, you're not going to say we're only going to look at dementia. You're going to look. So, for example, in our trials, we are measuring depression, social function, physical function. All of these aspects, which will contribute to both costs and potential benefits.
So, as a group, we should be looking wider at the whole thing. And again, it is an holistic thing. Not just holistic in our environment, but we should be looking at the whole process and how it affects.
Just to add to that, I remember meeting with a group that was a couple of people and hardly any funding about 10 years ago about trying to get social isolation on the agenda. And they've had a campaign about that for a number of years. Very similar again, both showing medical evidence about the impact of socialisation on ageing and some very good cost-benefit stuff around that again. You now look, and socialisation is a major bit of the debate around healthy ageing. And so again, it's like another anchor. So I'd agree with you, you don't just have the one. But I think the crucial bit is when we keep trying to say to people, well, you should look after your hearing more and value your hearing and hear well, and people just go, well, why? What's the problem? What's the issue? I think that's the point where you then come in with, well, if you want good cognitive health, well, give me your world famous impression of that. Well, not getting dementia, not being socially isolated, not being at risk of more mental health problems. Those three, you've pinged on the three biggest bits within the government's strategy on healthy ageing. And so somehow I think it's about how you absolutely infiltrate what is happening around hearing loss into those other agendas, because we're never going to have the power to build it outside of that. It's not life and death, although we can probably even prove that in some cases. But as far as the government's concerned, until you can have the argument where they say, oh yes, we understand about social isolation, mental health and dementia, you think oh, by the way, falls, how much is that costing you? Oh, by the way, actually it is early death. Well, actually it doesn't, because that saves you some money. So maybe that's why that's not such effective argument on that front. But again, if you're a politician, you don't want to go in front of the country and say, I know a reason why something that's killing you, but I'm not going to do anything about it. So even there, there's an argument.
Isn't it true too that even if one were to get a strategy over the line in the context that we're discussing this, there's always the danger that politics changes. And suddenly you get a new government, new strategy, not spending money, spending money.
Yeah.
Everything's thrown back up into the air.
Yeah.
So in a way, are we saying that it almost doesn't matter? Yes, we've got to do things, we've got to follow these paths, but it almost doesn't matter because long term things change.
But I think it doesn't matter because whatever government, whatever political persuasion you are, one of the biggest challenges you're going to have in terms of government expenditure is an ageing population. And somehow you've got to find a way of supporting that ageing population differently, because we can't afford to go on in terms of social care, in terms of the acute care model, with the model we've got at the moment. It doesn't matter whether you're Theresa May or Jeremy Corbyn or whoever's coming next. You've got that same, and it's the same across all Western democracies. They're all struggling with exactly that issue. And it doesn't matter in a way how much of your health system is personally paid for, state paid for. One way or another, you've still got to address that. And the only way people think of addressing it is to keep people healthier for longer so they cost less.
So working on the assumption that we're able over time to get all these disparate groups together to all work in harmony, it makes sense, does it not, to seek cross-party consensus over these issues rather than just working with the government of the day?
Cross-organisation and cross-party. Mm-hmm. So I think it's not just about the hearing loss sector talking to itself, it's who else are we talking to in ageing, in mental health. And I'm not sure, despite lots of attempts to do that, we've been clever enough about any of that. And I'm not sure what the answer is, because I've been one of the people that's tried and not succeeded, or only succeeded in very limited areas. But how we get coalitions that go outside of the hearing loss sector, I think that would make people take notice.
Is that worth another debate, another day?
Yeah.
How do we get everyone to coalesce around a...
I think part of the issue is how do we convince those other partners that hearing loss is even an issue. I think, again, the dementia thing has woken people up to that in the ageing sector in a way nothing else has. And we've tried before that in the hearing sector. It's been kind of, okay, that's all very interesting, and since the dementia arguments really kind of landed in the last 2 or 3 years, I think there are people in the ageing sector now sitting up and taking notice more. But I think it's obviously complicated because they have their own agendas and their own things to kind of push as well.
Thank you, everyone. Fabulous day. I think we certainly recorded it, and you'll see the results of that in due course.